two attendings here with us, because the way I like to approach these practice cases is that, there's no like right answer here. We'll actually approach the case together like it's a real patient. So you guys are the team. We also have a few attendings that can chime in, and then anyone that has experience with this, appreciate your guys' input, and then this way we can kind of all learn together. I personally have a lot of neurophobia. Neurocritical care is a very intense topic, and I really do rely on a lot of your guys' expertise here. So we'll approach the case that way. With each aliquot of information, I'll ask a question, see how you guys want to approach it, and then obviously I'll share some pearls that I looked up, not through my personal own experience or knowledge.
Hey, Uday.
Yeah.
Can you get back to the previous slide? I have more gray hair than that.
But that's a new situation.
Yeah.
We gave it to you.
Yeah.
You guys are too kind.
Right. So the first piece of information is that you get a call from the ER about a new patient that just came in, 56-year-old female. EMS was called for stroke-like symptoms. Last known normal was unknown. In the field, the GCS was 141, that's eyes, verbal, and motor. And so they were intubated and the family's en route. And that's the information that we have based on the chart review. This is what we know, that they have a history of hypertension. They're on 2 antihypertensive meds. What are you guys thinking?
They were intubated in the field.
Yeah.
I want to know what the neuro exam was prior to intubation, if we have one, if they intubated with any sort of paralytic.
Yeah.
And then what our neuro exam is now.
Yeah. So, I think that's a great question, right? Like, what was the neuro exam before this? Because this isn't a lot of information for us, right? I think really they just saw this comatose patient. They said they were concerned about not protecting the airway. But unfortunately, we were not able to get a good history on the neuro exam. So it might be something we're performing, on our initial evaluation. Anything else?
Did they get a finger stick? Did they get Narcan? Did they get anything else that could potentially correct something quickly? Just to rule that out.
Absolutely. So, those are like the things that we can address right away, right? Those are like, if you have someone, I think those are great questions to ask EMS also. So when you get a call like this, if EMS is still there, make sure they ask those questions. What was the finger stick? Because if it was low, you could push the D50. If there was any history whatsoever of an opioid overdose, this would be the type of patient that you would see. And it's something that you could fix right away. And then finally, like you mentioned, the cranial nerve exam, because then if you see any deficits, you're concerned about a stroke, right? So I'm
concerned about a stroke. Like, what would they physically see?
sorry.
So I guess, why are they concerned about a stroke? Like, why did they just jump to a stroke-like symptom? What are they seeing?
Yeah, maybe they saw some deficits. Maybe they saw a cranial nerve exam that was abnormal. I think that a patient that is not really responsive, I can't rule out a stroke, and it might just be a really severe stroke. So I want to be concerned about that. But I think, yeah. So let's just say that the sugars were normal. There was no, those are the only 2 meds that we know that the patient takes, and they really just found this patient not really responsive to pain or anything, or to commands. And then when they saw the patient, the vitals were off. The patient wasn't responsive, so they went ahead and intubated the patient.
Where did they find them? Or like, was there concern for trauma?
No concern for trauma, and they found the patient at home in her bed. She was very hypertensive when they checked the vitals.
Should also be concerned about like a post-ictal seizure, like.
Yeah, absolutely, right. So that could be something else as well. So really what I'm seeing is that here we have a really broad differential. Obviously, we're concerned about some of the more life-threatening stuff. Yeah, like you guys all have an approach to altered mental status. I think that I'll draw it out real quickly, but if you guys are familiar with MIST, anyone heard that before? Right, it's like metabolic causes, infectious causes, structural causes, and toxic causes, right? And then if you rule all those out, sorry, go ahead.
Uday, I'm sorry, can I ask a question? What time of the year was this again? I might have missed it.
This month, today.
Okay. Today.
Yeah.
Carbon monoxide.
Very helpful, thank you.
I think he was asking like winter-wise for like carbon monoxide.
Yeah, that actually makes sense, right? So, where to go? So just metabolic causes, right? You just go down, your BMP, if any of your values are off. You can look at hypercarbia, hypoxia, The ammonia levels, if it's super high, it can enter the brain, cause hyperosmotic shifts. Obviously, endocrine causes. I don't expect to see it unless it's a really severe hypothyroid case. I'm not expecting to see a patient like this. Infectious causes, cranial causes, extracranial causes. Obviously, if someone has a cranial cause, I'm more concerned. Whether it's like meningitis, encephalitis, or like a brain abscess. Structural causes is a big one, right? And this is these, especially like this structural causes you can rule out via imaging, right? Especially like ischemic stroke, hemorrhagic stroke, and then toxins. I think is a big one. When I first learned this, they showed me this little table. Drugs that you're prescribed, drugs that you take recreationally, and then ones that you're actively taking, the ones that you're withdrawing from, can all present with notable changes in altered mental status. But I think anytime I see any acute change in mental status, I'm running through this diagram in my head or this outline in my head and trying to figure out, okay, what tests do I need to order to rule all these out? So right away, I'm getting like a series of labs, and I think everyone here agrees that this patient warrants a CT non-contrast, especially after our last study, right? And so, what specifically in a patient like this who's now on sedation, has been intubated, are you guys looking for in the neuro exam if this is the only history that we've been obtained? The labs that you've gotten looked fine so far. The patient is about to head down to the CT, but what is your neuro exam looking like?
Other people's hands.
Yeah, I think it's cranial nerve exams, right? I mean, we're looking at that brainstem or the cranial nerves intact, so you're looking at, corneal reflexes, pupillary reflexes, things like that.
Cough, gag.
Yeah, exactly, right. And so we'll kind of get into that a little more.
I also think a key question is why was sedation started? She's unresponsive, so like, was she fighting? Was she, because like I hear unresponsive all the time, and you get downstairs and I'm like 50 of propofol.
Yeah.
It's like, what did she do? Oh, she's fighting. Like, that's not unresponsive. So it's like you have to sometimes dig for the definition of unresponsive.
Yeah.
It's not always.
So do you think in
We
this
don't
situation
know.
you're going to turn off the sedation?
Absolutely. I wouldn't put her on sedation. If she's truly unresponsive, I would leave it.
Okay.
And I mean, people don't like that concept, but
Yeah.
the reality is, if I don't know why their mental status sucks, I'm not gonna mask it with drugs until I, figure out. Yeah, granted, if you did give her a paralytic to intubate her, it would probably be prudent to put her on something for a little while, just because you can't rule out that she's gonna wake up and be paralyzed. But the reality is, if she didn't have a mental status and was unresponsive, I would doubt that you would need paralytics too.
Yeah.
So can I press you for a second?
Yeah.
So are you changing your paralytic strategy during intubation based on the patient's presentation?
To a certain degree, yeah.
So in this patient, what would you choose?
Well, so if I had to, do I have to paralyze her?
I think actually that is the best question.
Because if I don't have to paralyze her, I won't. But if I absolutely had to paralyze her, I mean, for the room, right? Can you reverse all your paralytics? Which ones can you reverse? And how?
Sex you can.
Yeah. So, I mean, if you want to, it's also the shorter acting one, right? If you're really concerned about a neuro exam and you need to paralyze her, you can do stuff that's shorter acting. Don't let Adam get in here because you say that you used it, but I wouldn't paralyze her.
And I mean, you're concerned about stroke and stuff, like there are any neurologic deficits in this patient, you're just gonna mask it with a paralytic.
And sometimes you have to, like sometimes there's an unresponsive patient that bites down. I get it. But if you don't have to paralyze them, I wouldn't.
Yeah, I don't know if anyone knows this, but I mean, are they cranial nerves? Sorry, go ahead.
No, I'm good. I'm sorry to interrupt.
Yeah, I was saying, I mean, the other concern would be paralytics is that here we're really relying on our cranial nerve exams, right? We're trying to assess that brainstem, and in that case, how much of an effect would paralytics have on those exams, especially like, your corneal reflexes and things like that. I don't know what the answer to that is.
And other stuff, like they're not gonna withdraw, burn, like, so you can't even assess for any of that. Are they posturing, not posturing? Are they withdrawing all four extremities to pain? Obviously, you can't check sensory and things like that, but like you say, corneal and all the other motor functions.
As much as I do not like propofol in the peri-intubation period, but it's fast on, fast off. You've got a patient that you need to evaluate their mental status quickly. It's not a bad choice here. I love etomidate. I'm a rock etomidate guy day in and day out. That's my go-to. But maybe for a patient where you need to know quickly what their mental status is, propofol's not a bad choice.
Serious.
Yeah, no,
I mean,
yeah, I think this patient I'd be hesitant to use ketamine if the blood pressure was that high.
Right.
Sorry, Uday, I
Right.
think we've completely hijacked your entire presentation.
No, I mean, this is the goal. This is like
Go ahead.
what, there's not much for me to add here. I'm gonna be asking a lot of questions, and I think, I'm here to learn from you guys in this case. Obviously we take our patient that we're all taking care of together down to the CAT scan. We are concerned about this patient, so we go to the CAT scan with them. We obviously call the stroke alert because we don't have much info here. And this is what we see. So I try to take images at each level from cranial to caudal. Does anyone want to take a shot at interpretation? Before we get on a call with, I think here, definitely with neurology.
is it CAT scan?
Yeah.
Any of the residents want to take a shot at it?
So obviously this is a CT non-con, right?
Is
And
that,
If nobody volunteers, I'm gonna start calling people out.
they're volunteer,
I was gonna say bleed, but
right? So how do you know if they bleed?
So, but as a rule for radiological findings, just describe what you see and then interpret it when you're done, but like, just describe what you see. So like, if you're saying bleed, maybe back up a step.
attenuation.
So you wanna look at like the color, right? So dark, hyper, right? Do you see sulci or gyri?
Yes.
Okay. And then in this situation, is it hyper or hypoattenuated?
Sorry,
Is it hyper or hypoattenuated?
hyperattenuation.
Okay. And then what do you see around the hyperattenuation?
Hypoattenuation.
Right. So
And where is it located?
for anybody.
yeah, and so are we looking at, so
Very ventricular, yeah.
Yeah.
Right, so hyperattenuation, CAT scan, white, blood, right? There's areas,
Right.
yeah, you're right. And the areas around it, that hypoattenuation, that's your edema, vasogenic edema that you're seeing from the bleed.
so does this explain our patient symptoms? Yeah, I think it generally can have a very good explanation, right, for this, like what's going on. So really what we're seeing is that we're seeing hemorrhage, right? We're seeing an intraparenchymal hemorrhage in the actual parenchyma. And then what's concerning here is that you actually see some of that blood entering the ventricular space, right? So when you see a scan like this, what are some of the things that you guys are thinking about? Some of the things that you're going to be discussing with the neurologist? You're trying to decide, is the bleed intraventricularly, is it parenchymy, right? This is how you differentiate, like, what kind of pattern it is, right? Like subarachnoid, subdural, epidural, whatever. This is obviously an intracranial hemorrhage that's entering the ventricles. And then if I'm entering the ventricles, what are the things I'm getting concerned about? Is it going to cause an obstruction, right, of that ventricle? Because if it causes an obstruction of the ventricle, what's going to happen? It's going to cause hydrocephalus. And so these are the things that I'm going to be talking to the neurologist about. And in this case, yeah, it shows a large left-sided intracranial hemorrhage with intraventricular extension in the region of the basal ganglia. And so, not that this matters much in this acute case. I need to get on the phone with the neurologist right away and figure out a plan, as well as possibly, the neurosurgeon. But I think the history kind of displays this picture. The patient had uncontrolled hypertension. A lot of these patients who who may have, like, I think in the basal ganglia, you see those aneurysms. That plus uncontrolled hypertension, they're prone to this. And that might be what happened, not that it's going to change our management here. So,
Well, I do think that is an important point, Uday, when you're getting the initial head CT and you're seeing this, you do want to ask, well, why does the patient have this? So yeah, I'm looking at the clinical scenario, the most likely cause is probably it's a hypertensive hemorrhagic CVA, but especially if you have it in another area that's not typical, it would be important probably to follow up with some potential like angio imaging because they may want to know if there's an aneurysm or something else there causing it.
yeah, 100% agree.
Dr. Meridios, that's a fantastic point. And Uday, do you mind if I ask you a question? And actually,
Yeah,
it's
go
not
for it.
just you. I want to ask all the fellows, residents, you get to pass the buck this time. So you see this imaging for a patient, and then all of a sudden they start getting airway compromise. Then you start getting concerned they have to be intubated. What are you reaching for? What are your sedatives?
I mean, I guess no matter what, I'm going to be concerned about intubation because I know that, just procedurally, it's going to raise the intracranial pressures with this. So I'd want to avoid something that's going to cause profound hypotension unless the blood pressures are high. And obviously, like we talked about before, something that I can use really quickly, potentially like maybe propofol.
Yeah, so this is a situation where and I think the evidence has gone back and forth. I think ketamine is something I'm steering away from. It's not that, I think the evidence is probably pointing to the fact that ketamine probably doesn't induce ICP to the degree that we think it does, but I don't want to risk that. These are patients, like you were saying, Uday, like propofol, etomidate, those are going to be my go-tos. And these are also patients where I'm going to intubate them. I'm probably going to put them in an angle. Like we always talk about, like bring the patients down flat so you're comfortable. This might be a patient where I'm dropping the bed as far as I can and putting them at a 45-degree angle. Again, because you do not want to induce that intracranial hypertension. You do not want to increase those pressures. You're doing the best you can to try to control those aspects of their vital signs.
And then would this be a patient maybe that you'd be considering pre-treating with some kind of like fentanyl or something else to potentially reduce the pain stimulus that would be causing increase in intracranial pressure?
Dr. Medeiros, that's a really good point. We always talk about like fentanyl, lidocaine, those types of things. I think those trials have actually turned out to not show a ton of benefit. However, if I'm worried about a patient that's in pain, like you were saying, pain's only going to raise the blood pressure. So I think there's, when you're doing risk harm analysis, I think the potential benefit definitely weighs into what you're saying, that like maybe a little bit of fentanyl, if they're in a lot of pain, could definitely help to control their blood pressure. These are the worst. It's just so tenuous. It's so scary. Even as an attending, these are the patients that I worry about more than most.
So I mean, that's a good question. We'll kind of get into that in a second. So what I will say is that we see this, and I completely agree with Dr. Bonk. These patients are very scary, hence the neurophobia. Your exam, you did do a thorough exam. What it showed was that the right pupil was fixed and dilated. The left pupil is pinpoint. They are initiating breaths on the ventilator. And that's what you have in your exam so far. And I apologize because that's my limited exam. That's what I have to give you. So, your next step is you're going to take this patient up to the ICU. You're going to get on a call with the neurologist. You're going to tell the clerk right now to put a call to the neurosurgeon. And then on your way up, you are stopped by the family. You've had a chance to do a bit of your clinical exam. Obviously, if you see the family right outside the radiology suite, you know that you're going to be talking to them in a few minutes. You're welcome to go do any additional exam. But when you walk out that door, the husband is right outside the room. What are you going to be telling the husband based on what you have right now, based on what you see on the scan? And the reason I ask is because I think in these situations, there's three components to approaching this case, right? There's the medical management, which we'll get into. There's the surgical management, which we'll get into. And then there's the family management, right? I think that's a big part here because you have a patient that really can't advocate for themselves, and you're going to be relying heavily on the decision maker here.
So right now, it looks like the patient has a brain bleed. We're getting in touch with neurosurgery to see what the next steps are.
Yeah.
Keep them updated.
Yeah. I mean, I think I agree with that initial call when the ER said that, they called you because the patient's intubated and doesn't look good. I agree with them, right? This is something that's concerning. And that's what I'm telling the family right now is that, this patient is very sick. This is what I'm worried about. And that, you are going to need some time to figure out how bad this is. But you know that no matter what's going to happen, the patient is going to be here for a while, that this is going to more than likely be a poor outcome. And it's too early to say, but you are going to be in close communication with them. I think getting their number, getting their cell phone number is important. So that way you can document it, the family can be in constant, easily reachable. And then you let them know that, exactly that's my initial plan, is to keep a close eye on them. They will require very close monitoring over the next couple hours, over the next day. They'll require, obviously intensive care management. And then you'll see a lot of collaboration with the neurologist and the neurosurgeon. And then I think, I don't know, I mean, what do you guys think? Is it too early to start having that discussion with the family regarding goals of care, regarding what they want? Because right now you have very limited information. Obviously, your priority right now is to get back up there and get on a call with the consultants.
If something were to happen overnight, you kind of want to give them a heads up, right? Just, you don't want to assume it can resuscitate anybody. So you should feel like in the event something were to happen,
Yeah.
would you want to think?
Yeah. Cool. Yeah. And then I think I would mention, like, these are the things that I'm looking for acutely that I might be calling you about. We're going to do our best to stabilize this patient, but I think there are certain things that we look for in these cases that the patient could cause, an acute change, which would make me concerned. At that point, I think it would be worth coming to the hospital. Okay. So now you get on the phone with the neurosurgeon. What are the things that you would want to talk to the neurosurgeon about? The neurosurgeon obviously is going to give you their opinion on whether this patient is a surgical candidate for evacuation of that hematoma, but also, things that I think we're going to be talking about is placement of intracranial pressure monitoring, possibly a drain. And then the other things that they can offer in this case are craniotomy and craniectomy. So specifically I guess more for Dr. Bonk and Christine, like what conversations have you had with the neurosurgeon in the past when you see a patient like this?
So, you guys will see this when you go to Cooper. I've seen, at least I saw a couple of people like this when I did my neurosurgical rotation. But typically, kind of like what you were saying, at least based on the, in my experience, based on the location of that hemorrhage, they're not necessarily a candidate for like going in and cleaning out the blood. That's not like just based on the location of it, it'd be very difficult to do. But this is somebody that I could see definitely who's going to be intubated long term. And there's also somebody who potentially is going to be getting an EVD, basically the drain where they go into the ventricle, just to like prevent the hydrocephalus or increase in intracranial pressure. And then this somebody is probably also over the next like 24, 48 hours, depending on how the bleeding and how the scans progress. This is somebody who's probably going to be on a crani watch. At least that's what I've experienced. I don't know if you have anything different to offer there, Mike.
No, I completely agree. It's these patients, depending on the institution that you're at, you can put a drain in to try to evacuate it, but really it's just like those constant neuro exams to make sure nothing's changing immediately, just in case you have to move towards a hemicrani, which obviously would be the worst case scenario, but kind of is what it is.
Yeah, and I think you guys both bring up good points. It's very institution dependent. There's some institutions that are very aggressive very early on, especially when it comes to putting in, intracranial pressure monitoring, a drain, and obviously I've been at other institutions where we're not as aggressive, or we're more quickly, more likely transferring them out to an area that will be a little more aggressive. But I will say that, the trials that we kind of see in the STITCH trials, and then also the CLEAR trials, which kind of talk about surgical management in these patients. For example, the STITCH trials looked at, medical management versus early surgical hematoma evacuation, showed no real difference in outcomes. What they did show was that in both trials, that when the patient's severity got worse, is that they ended up doing surgical evacuation later. But I think it's expected that in trials like this, it's going to be hard to see much of a difference because obviously the prognosis overall is pretty poor. And then the other thing to keep in mind is that none of these trials addressed cerebellar hemorrhages. They all address supratentorial hemorrhages when it comes to surgical management. Cerebellar can be pretty scary because the bleed is right next to the brainstem. And then on top of that, when herniation, you can actually get supratentorial herniation if you have a bleed there. So the guidelines that were published by the 2022 AHA guidelines are based on current evidence and expert opinion. And what they recommend is that you're definitely considering surgical evaluation for large volume bleeds, acute neurologic deterioration despite medical management, brainstem compression, and hydrocephalus, especially for these cerebellar hemorrhages. But I agree that it's important to have these discussions with neurosurgery early on, because say you're in your third or fourth day and then you're talking about a craniotomy or craniectomy, I think then it might be too late. I think it's something that you want to talk, if you're going to do it, talk about doing it early on within the first day or two. So now they're your patient, right? You are now medically managing this patient. What are the things that you're doing? I mean, this is like your classic illness script for an intracranial hemorrhage. What are the things that we can fly through this? What are the things that you're going to kind of be doing and taking care of to get this patient stabilized? Yeah, so blood pressure control is a big one. What's our goal blood pressure?
160. Some say around 40. I think it's 160.
Very limited.
Yeah, so blood pressure control, we'll talk about it, right? I mean, so there's quite a few trials on this, and there's obviously new guidelines. I've heard also different things about how aggressive be blood pressure, but I mean, the idea is pretty simple, right? Like, Dr. Baum talked about this in the last lecture, but you know, your brain is a limited space. So I think they call it like the Monroe-Wiley doctrine, where you have a skull and you can't really expand the skull, and you have to fit fluid, brain tissue, and anything else, the perfusion that you're giving into that space. So if one thing increases, then everything else has to decrease, right? And that's why we kind of get like that equation that your cerebral perfusion pressure plus your intracranial pressure is equal to your MAP. And so if your blood pressure skyrockets, then your intracranial pressure might go up as well, right? And because everything else has to kind of balance out. And so what's happening here physiologically is that you have a bleed, and it's causing decreased blood flow back to the brain because there's less space for the blood to enter. And then you are having cell damage. And with that cell damage, it becomes edematous, and that's why you get herniation. So agreed, blood pressure control is extremely important, especially if the blood pressure was really high in the beginning. You know, we've seen that number 140 to 180. I think it's hard to set a target, but I do also think that, and this is based, I think I forget which trial was, I think the ATTACH trial, which showed that you saw harm from lowering the blood pressure too much. Because now what happens if you lower the blood pressure too much? Then you'll dramatically decrease your cerebral perfusion pressure. And then whatever chance you have of preserving the penumbra goes away. So yeah, 140 to 180, 140, don't be too aggressive. How are you guys addressing the blood pressure?
Independent.
Yeah, I think it's institution dependent what you guys have. I think here we have the carping. That's what we're reaching. And the good thing about that one is it's really easy to titrate. The risk of that drug is that it can also stay in the system for about an hour. So I think once you maybe, I don't know how you guys approach it, but maybe like start at a certain amount, maybe start at 5, increase it slowly until you reach your goal. And then once you reach your goal, maybe consider cutting back a little bit because you know that you have a lot of the residual drug in there. It's going to be lasting a while. You don't want to risk overshooting your target. But it is a great drug to control. All right, what else? So there was something else that was mentioned. Yeah, so serial imaging, we'll kind of get to that in a bit. So, you know, next probably will be any acute change or in after 6 hours. What else can you do now? Sorry?
Hypercapnia.
Yeah, so permissive hypercapnia, that one is interesting, right? So, and maybe Dr. Bonk, you have some thoughts on this, but like, are you shooting for that PCO2 lower, you know, that 30, 35 lower right away, or are you waiting for an acute change? Because my concern would be is that if the CO2 is too low, then you might get some vasodilatation and alter your intracranial hemodynamics too much.
It only works transiently, so
Yeah.
really you only do it for like under 2 hours.
Yeah.
So there's no point in prophylactically doing it
Yeah.
because it won't help you. So like exactly what you're saying. So if something changes, then I would do it while you're getting to the OR, for
Yeah.
instance. But like just putting her on a rate of 30 is not gonna help you, unfortunately.
Yeah, I agree.
Yeah, Dr. Gulati, you're going to put me on the spot?
You are a pulmonologist.
Which obviously is also
Not
a
a-
neurologist because it's, you know.
Yeah, it's all the same.
No, I agree with Sonia. Like if you're you know, with those patients you're really worried about intracranial pressure, you can hyperventilate them acutely, but you're going to run into the exact same problem, like you said, that when you drop that PCO2 too low, you're also inhibiting the perfusion of the brain. So it's a tough situation. I think if in the like literally immediate situation where like I am immediately concerned that somebody's, you know, herniating or that's kind of the main issue. Yeah, I'm going to hyperventilate them. I'm pushing that hypertonic saline. And again, like when I say hypertonic saline, I mean that 23% hypertonic saline, but that's so transient. The immediate hyperventilation is going to give you very, very short amount of time. But at the end of the day, that short amount of time might buy you enough time to actually get a definitive intervention that, as intensivists, we can't do. So, just something to consider.
Yeah, absolutely. So we kind of touched on a few things that we can do in medical management. The other thing that we just kind of talked about already. This is where I put a lot of the stuff from. I think it's a great paper. They have some really interesting way to phrase the recommendations. But yeah, we talked about blood pressure management. Obviously if someone is a baseline hypertensive patient, maybe don't be as aggressive to try and preserve the penumbra, but obviously if you see changes, then be aggressive. The sodium, not a lot of good evidence behind it, or I guess I should say the evidence is mixed, but boluses over drips, trying to get that intracranial pressure under control. If you have a monitor, then it's going to be very useful, especially as you continue to manage the patient on when to push the hypertonic saline, 23% better than the 3%. Also consider mannitol. And then how are you guys in this? I mean, we kind of talked about this earlier, but how are you guys balancing here the use of sedation, and paralytics, to reduce demand in the brain versus to get a good neuro exam for prognostication purposes?
Fast on, fast off. So I would only use things like propofol that you can turn on and off. And
Yeah.
we did a lot of neuro ICU in residency and did a lot of these patients, and they're on the vent forever.
Yeah.
All of them get trached. Our neurosurgeons trached their own patients. That's how many they did. And all of them are like Q1 hour neurochecks, and that literally means every hour propofol's held for like 10, 15 minutes, and they get a neuro exam, and then they restart the propofol.
Yeah.
And any little change, you go right down. And there are like a couple of scores that you can calculate based on imaging and like different signs that will give you an idea of what the likelihood is of that hematoma expanding versus not, which is really helpful, especially when the ones where you're like even more concerned, just in general.
Is this the ICH score?
There's like I think it's called the BAT score.
Mm-hmm.
And the ICH score is like 30-day mortality, which is really helpful for family.
Yeah.
Although recent literature apparently says that we're probably just not waiting long enough.
Yeah, exactly.
So like maybe the ICH score is bullshit,
Yeah.
but
Yeah.
I wouldn't want to wake up 6 months in and be trached and have it thing in my brain, but that's just me.
I think the scoring systems here are pretty useless. We just had a neurointensivist walk in, so we can obviously get more input then too. But I think the ICH score, obviously, I agree.
I see that says ICH.
Yeah, it's not going to be that useful because one of those things is that so much of what we're doing right now can affect that score, and that a lot of when they use that score for external validation, is a lot of those patients, the families decide to stop care. And so, the mortality was end up being a lot higher. I think here it's good to kind of get an idea of disease severity, but I wouldn't use it so much to decide on, prognostication and things like that. The papers also recommend for seizure prophylaxis that not just doing empiric anti-epileptics is just actually getting evidence of seizure activity, or if they might have had a prior seizure, then your threshold might be lower to start anti-epileptics. But otherwise, you're not just empirically starting it.
Does anyone know what the safest AED you never needed was? About 750 milligrams twice daily of Keppra.
Mm-hmm.
So sometimes the time you treat the neurosurgeon, sometimes with that. But.
Yeah.
more often than not.
So obviously, if you do see a witness seizure, any activity, if you decide to put cerebral on, then definitely do start anti-epileptics to minimize any brain demand. But yeah, and then we talked about, I think you mentioned this before, the body likes to be normal, so maintain normal blood sugars, normal temperatures. We talked about head of bed elevation, so you can improve venous outflow, and then hyperventilate if you think they're acutely herniating. I would hope that in this patient we have an intracranial pressure monitor to help guide us, but obviously we don't. We're relying on clinical exams. So you brought up a good question.
Can I just
go ahead.
I'm gonna emphasize the normal glycemia normothermic thing, because that's huge, and that's actually not that hard. But don't let their sugars be 350 or 280 or let their temperature get to 38.
You would really don't let their sugar be like 60.
But really don't like
Like,
that. No, exactly, and that's the thing, it's like, it is a balancing act.
Is that, I'm sorry, is that Dr. Zarbiv chiming in?
Yeah.
Yes.
So I mean, I have to ask his qualifications to talk about anything that has to do with neuro ICU. Like, I just, again, not, just curious.
There are no qualities. I played one on TV. I agree with Tony. They're cheap interventions for what it's worth.
Yeah. I think physiologically, theoretically, it does make a big difference because they are osmoles, right? And any big changes in your osmoles are going to affect hemodynamic shifts in an area, which is in an area that's so small, and that's what we care about right now. We're trying to minimize worsening intracranial pressures, and if these are off, then they can actually absolutely affect that.
I have a question. This might be a dumb question, but for like this patient, the bleeding caused some edema. So like with patients with tumors that have edema, we give steroids. Do you also do it in these situations? You don't?
Yeah, the studies haven't shown benefit of steroids in acute intracranial hemorrhages, and it actually might make things worse.
Okay.
But you know, like Christine mentioned earlier, if you are suspecting that this is not a hypertensive case, then your management might actually be a bit different. Which is perfect timing, because you know, when are you going to consider other imaging, right? I mean, we know that we're going to be getting serial CTs. We'll talk about the utility of serial CTs in a second, but you know, when are you considering an MRI or invasive angio? Yeah.
So it is correct. First of all, you're very, very good at making presentations. I'm actually very serious. Really important skill set. But you're differentiating right cytotoxic and vasogenic edema, right? So, but it is right. There have been many studies that get various, different ways to kind of reduce the mechanism is very different. But yeah, I mean, it's probably potentially harmful. But if you think that the reality, I mean, we're going to get this now on this slide here, but differentiating the sodium mechanism, is important. Changes a lot of management.
Yeah. So, I mean, basically what I was getting to was like, regarding the additional imaging, is that if you're suspecting that this is due to a tumor, then I think that your neurosurgical colleagues might be more open to getting it. They might ask for more imaging because they can better figure out what's going on, especially with like MRI imaging. Obviously be careful with like, and maybe Sam, you can speak to this more about like, are you going to get an MRI with or without gadolinium, because gadolinium will hide the bleed, especially like the first 2 days. And then with invasive angio, if you're suspecting that there's a vessel that you can fix, like an aneurysm, then you might be doing more invasive angiography. But obviously, I don't think we'll be doing it here. And then with the daily CTs, what are we looking for on the daily CTs, or like those frequent CTs? Obviously, one of the things that we're looking for is if we're seeing an acute change in the size of the bleed, but what else are we looking for? Yeah, edema. And then I think another important thing is looking at that brain specifically. Are we seeing that, yeah, exactly, right? Because if that area is being affected, then. Yeah.
Wait, can you show me the first scan?
Yeah.
And also, I'm concerned for hydrocephalus in somebody like this with obstructing hydrocephalus because of where her bleed is looking.
So let's few instances that we actually use.
Okay.
That's the biggest one.
Cool.
Yeah.
Now again, the problem is.
So this patient did end up getting, we are monitoring intracranial pressures overnight. We did all these things for medical management. We've spoken to the neurosurgeon.
Did you guys get an adrenaline? ABD?
Yes. There's a drain in, there's a monitor in, but otherwise no further surgical management for now. All right, so fellow was on overnight. You're getting sign out right now. Overnight, they struggled all night managing the pressures. It remained high, 23, 24 throughout the night. They were pushing multiple boluses of hypertonic saline. They called the neurosurgeon right before sign out. Based on how quickly this is changing and evolving, they don't think that they can offer anything right now. They don't think the patient is going to be a good candidate. Recommend continued medical management and serial imaging. So you go back, and the first thing you do is you go back and do your exam. And now you see, because you examined the patient multiple times yesterday, we had that asymmetrical exam yesterday where only one pupil was fixed and dilated, the other was pinpoint, and now you see this.
So what was that, the fixing that, the other one is pinpoint, that's a herniation syndrome, right? That's worth memorizing too. There are herniation syndromes, right? Of which that's a very ominous sign, the transitorial herniation.
So when you guys seen this, what are you guys concerned about?
A lot.
Yeah, a lot, right? And I think, the family's here, it's during the day now, so the family's here and you're having that discussion with family. And so, obviously here you're concerned about persistently elevated intracranial pressures. You're not going to be offered any surgical management for this case for whatever reason. And the CT, shows worsening edema, some evidence of herniation. You're concerned about that brainstem. And, obviously the husband's been on the internet all night and now they ask you, they have a pretty good idea that the patient is doing poorly and they ask you, is the patient brain dead? How are you guys approaching that conversation? I tried to make this not an intracranial hemorrhage lecture because, I'm sure Sam can give a lecture one day.
Probably have to do some more tests to determine that.
Yeah, I think this is a very tough question to answer, right? Not one that just doesn't have a lot of effect on what the family decides to do, but also, medical and legal implications, right? So you're seeing that this is not just a brain bleed anymore. This is increased intracranial pressures, this herniation, you're not being able to successfully drain on the EVD. And then you might say to the family, yeah, I think you might be right. And I think it would be worth doing a formal assessment. That despite doing everything medically that we can, this might have progressed to brain death, and we should evaluate that with formal criteria. So things that you kind of want to get from the family, I think at this point is, do you want to go through the process of the formal criteria, or versus, maybe if the patient was a bit older, maybe the family's already decided that they don't want to be aggressive and maybe they want to make the patient comfort care already. And if in that case, you don't have to do the full formal brain death exam, especially if you've already if the family's already gotten there. But otherwise, then you have to let them know and kind of prepare them for that this might take a while, that there's plenty of reasons why this exam might fail and you'll have to keep repeating it. One of the big reasons being is you have to wait for the sedation to wear off. You have to wait 5 half-lives for that sedation to wear off. So you'd have to call in your pharmacist, working with them closely to try and prepare them and work with them to figure out what would be an appropriate amount of time to do this. So, potential reasons to pursue a formal brain death diagnosis would be to resolve any confusion regarding goals of care, to help with any issues with decision makers, especially if there's multiple. It can also be a reassurance for the family that nothing else can be done. It would also address any future issues you might have legally regarding decisions to withdraw care. And then another important consideration is that this is required prior to organ donation, like we saw in the last case. And there's all these other ethics on, brain death examination, like, do you need to, I think different societies have different recommendations on it or views on it, but is it complete brain death or is it just like, your brainstem death? Or I think both say brainstem death, but is it complete brain death and does it involve the pituitary or not? And so, yeah, we kind of already talked about this, how the physiology there, but so what's your guys' approach to the brain death evaluation?
Who thinks a patient is actually brain dead?
This one,
Yeah, this one.
I probably get it.
No, who actually thinks that, like, we tell them nicely one thing, but in your head you must have a thought, like, right, like your pupils are fixed as of it, is he brain dead? Who actually thinks the answer is yes? Nobody? I do.
I do 100%.
Yeah,
Probably is.
right. But I think that's very important to the approach, right?
Yeah. Even if the exam tells you that, you're not getting, you can do your, reflexes right away, and we'll talk about it in a second, but, before I go out, I will probably do the quick cranial nerve exams and, get that confidence that I need to let that family know, because I think, yeah, if they're open to doing comfort care sooner and they don't have any concerns about that, then yeah, potentially doing that. There's also ways to do like an informal apnea test where you don't have to go through the entire process just to know. Obviously, for all the other criteria like organ donation, things like that, you just have to get the formal testing. So Really, I think it's like a 6-part approach. First part is obviously to make sure there's no confounders. So that we talked about that skeleton, right? That missed skeleton. Reapproach that skeleton in your head. Make sure there's nothing else that could be going on that could affect the accuracy of your brain death exam. Meaning that, we talked about the toxins, right? You have to wait the 5 half-lives for your sedation to wear off. You might be considering doing 304s to make sure that the paralysis, the paralytics that you use to try and control the increased intracranial pressures is not playing a role here. And then your clinical exam, right? So seeing whether this patient is someone that you want to decide whether or not they're brain dead. So that's what kind of Sam was talking about, is that the reflexes, the exams that you're doing, no facial response to pain. Obviously, you're expecting some spinal reflexes. And I mean, really, in these cases, your spinal reflexes are actually going to be more profound than in an awake patient, right? Because in an awake patient, you are inhibiting your spinal reflexes actively, right? But in a comatose patient like this, you've gotten rid of all that, and now you've disinhibited your spinal reflexes, so they might actually be more profound. And when you're doing this with a family at bedside, they'll see responses, right? And you don't want for them to be confused that this is someone who's responding to pain. So yeah, you have your pupillary reflexes. One of the things that people get concerned about is locked-in syndrome. You shouldn't see large dilated pupils with locked-in syndrome, but you'll see really small pinpoint pupils. It's not a hard and fast, obviously, but this is what you're really trying to rule out. With your corneal reflexes, things I've heard is, don't use the drops. You really need a good amount of pressure, so use a Q-tip. Really get at the cornea, not the sclera. Do you guys remember all the caloric stuff from med school? But really just, grab a 50 cc thing, push it in there. If you don't see a response, then it's abnormal, right? Or if it's asymmetric, then it's normal. But a normal response is if you push it, you can use it on a lot of cows. There's like a fast response and a slow response. And this is the direction of the fast response. So cold will go opposite and then toward, and then warm will go toward, then opposite, warm, same side. And then obviously with your cough and gag reflex, where they use a yank hour, like really put a good amount of pressure back there, and then use the inline suction with the endotracheal tube to test the cough. Obviously, the only way to get good at this is to practice it. So, next time you unfortunately come across a patient like this, I recommend going in with the fellow, going with the intensivist, and learning how to do this exam. All right, so now you've seen that these are off, right? Now you approach your testing. So it's very, very important to make sure this patient is hemodynamically stable for this test, because if they're not, then you're going to risk having to stop the test early. And I mean, I'm sure you've performed this a couple of times, but what are the things that you're doing to make sure that the patient is stable enough for this exam? Like, are you setting MAP goals? Are you setting blood pressure control goals? How much are you pre-oxygenating the patient? Things like that.
For napkins,
yeah.
For napkins, you have 7 normalized CO2.
Nobody's asking what are your, there's like a textbook answer, right? So like,
yeah.
The answer is, so it depends on sort of how you train, right? So like, you guys were not, I'm getting old. Mike, we're getting old, but when Kia was a fellow, for example, were you there with me that time? The guy exploded like a Oompa Loompa?
Yeah.
Right, so my point is though, like that, so there was a guy who were doing, was like a cardiac arrest, and bottom line was, it depends sort of on what you consider to be hemodynamically stable. So in this particular situation, it's okay to use vasopressors, right? That's allowed. The issue was, I guess, in this guy, he may have had like a dissection and about 20 of epi, he'd been ruptured, he'd blow up like an Oompa Loompa. My point to that is, like, what do we consider? There's something that you have someone already on like 4 vasoactives, very unlikely that they're going to tolerate an additional component of acidosis, right? So that's actually what you're doing with an apnea test, right? You're looking at when you confirm brain death, you were expecting acidosis because you're not obviously breathing, right? So, but it's, the to me, like the way I treat it is that your go-to test, if you will, is is clinical, right? It's all about the exam. So I think my threshold push the envelope, if you will, a bit more than. And I think that's what we do better in critical care kind of than you might see outpatient neurologist, right? Like I'm okay with a couple, adding an additional vasopressor just to kind of get through the apnea test, right? You have to also consider in order to do a confirmatory test, which I'm sure that we're going to get to, right? They've got to pack the patient up. Sometimes like a 2-day study, depending on what facility you're at and stuff like that. But the one thing I would just want to say is really important. I don't know what you have to have a mechanism that makes sense to do, right? So so in this case, we obviously have one, right? So the way you document this is everything, right? So I will always say the mechanism of neurological injury is intracerebral hemorrhage with probably rupture into with IVH, right? So, but that's a really important thing. So if somebody comes in
like the brain looks normal on scan and you have nothing.
Yeah, and you don't really exactly like an overdose or something, right? And maybe they actually are great, right? But you don't have a clear-cut mechanism, right? Then you want to think about, like confirmatory test and actually confirming sort of that there is no intracranial flow. But the answer is, as long as they don't have a giant dissection, you're probably okay.
Yeah. I think that's what I was trying to get at is like, are you just gonna start
I just wanted you to tell the
story. It's pretty scary to see. But I think it's fair to say that, you can actually have pressors ready to go because you know that the acidosis is going to cause them to be hypotensive. And you're trying to avoid that early termination of the test because you're trying to get that diagnosis. You're trying to get those ABGs. I would say have the A line in place. That way you can, absolutely. You can withdraw the ABGs faster.
Has anyone ever tried to do an apnea test without an A line? I have.
Never.
And then obviously we talked about, right? Like the brain, you're at the pituitary, right? And if you're going to get mass in the pituitary, you're going to get central DI. That can cause profound volume loss. So make sure you address that. And I think, are you fixing it first with the vasopressin drip, or can you start the vasopressin drip and then do the test and keep them on it to keep them stabilized?
So that's a loaded question, right? So the issue with that is, that or like high dose steroids and stuff, right, is that sometimes it actually slows down the process, if you will. So you could actually drag out the ability to confirm brain death. But I also think that I have no issue with that either, especially given this mechanism. The short answer would be yes, probably.
Yeah. I think it'll come down to hospital policy because every hospital has a different policy. And what did they say? I'm assuming most hospitals won't have any detailed criteria for that. And then how are you pre-oxygenating the patient? The idea is you don't want to let de-recruitment end up altering your exam. I mean, if the patient's on a ventilator, are you switching them to CPAP mode? Or are you putting them on, CPAP and with a T-piece or something like that? I know when I was in med school, what they did was stuck a nasal cannula down. But then don't you risk pneumothorax for them?
Yes, yeah. That's Mike Bonk, he's a pulmonologist.
That's what I said. Dr. Bonk?
No, I gave that up years ago.
So then, and then, finally is performing that formal apnea test, right? You're trying to prove that the patient becomes hypercarbic as you cut off the ventilation. And I think 10 minutes is a decent amount of time. I've only, seen this or done it once or twice. And what we did was we drew blood gases, at 5 minutes or 6 minutes, and then again at 8 minutes, every 2 minutes.
What's the cutoff? Does anyone know how long you can keep going for? The answer is there's none, right? So if you don't, but the issue is patients won't tolerate it from a non-brain perspective, right? But by 10 minutes, if you're not really getting there, you could, and but the patient is stable, you absolutely can continue to hold the course.
Yeah, and I think keep drawing the blood gases because you just need that blood gas to show that it went up by 20, and you don't want to end up getting the blood gas. You don't want to have to wait until they're unstable to get the blood gas. But usually 10 minutes is adequate for this type of exam. Your targets are like a pH less than 7.3 or a PCO2 20 above the baseline. The caveat to that is the reason it's 20 above baseline, not 60, is because some patients are hypercapnic at baseline. And I think that if you don't know the patient's baseline PaCO2, then you should not be performing this test. And then that's when you're looking at the ancillary testing. Other things to look at is obviously, I think that's pretty much it. I think you've also seen this before, if the patient, when we talk about hemodynamics, if the patient's hypovolemic, then, what's the heart going to do, right? It's going to become hyperdynamic. And then if it's contracting really hard, then it might actually trigger the ventilator and might actually overbreathe. So I think we were in there once, and then the nurse was concerned that the respiratory rate was set to 14, but they were breathing it higher than that. And it's obviously the neuro exam was pretty concerning, but I think that we saw the volume size was pretty down. That might have been triggering the ventilator. So yeah, I mean, you stabilize the patient, you prepare them for the test, you grab everything that you need, you perform it, and then you decide. And so we talked about ancillary testing. You don't always have to get this. It's going to vary by shop, but there's different ways to do it. Obviously, if there's any indications where your cranial nerve exams you can't do, or you can't perform the apnea test accurately, then you're going to be looking at ancillary testing. I've actually never seen these, but I think reading up about it online is pretty cool. Like, this is the empty light bulb sign and the hot nose sign. And the idea is that you're not seeing any blood flow to the brain, right? Pretty cool.
It is cool.
Yeah. Then you can do, angiography. This is like the gold standard where you're seeing no blood flow to the brain. And then obviously transcranial Dopplers, what you're seeing is that it will go in one direction and stop, and you don't see it go the other way.
It's a requirement here for the ancillary.
Yeah. Oh, cool.
Yeah.
In most places that I've seen, at least,
So you're gonna have to.
there needs to be some sort of confirmatory. You can't just do one test.
You need to examine.
Yeah, you need two.
So for Inspira, you don't actually have to have one of these exams. You can do 2 physical exams. You can do a like we talked about the CO2 retention exam. My own practice is, if it was my loved one, I would want a perfusion exam, and so that's played into the fact that that's what I do. If we do the initial exam, obviously the CO2 retention is confirmatory, then I would prefer a perfusion exam. But again, that's my own practice, but it's not necessary from a legal standpoint or from an Inspira standpoint. That's just my own clinical practice.
It's mixed here, because on that lady that I had, we did the brain, like neuro did the brain death, and then we did the apnea, and then they still required us to do the ancillary test for whatever.
Was it gift of life?
No, it was like Inspira policy.
But I mean, was it a gift of life patient?
It ended up being.
Yeah, so sometimes gift of life has like specific requirements about when they will accept like brain death as the declaration instead of doing a DCD. That's what I've been hearing at least.
But yeah, whenever you guys have a patient that you're looking at for doing brain death testing, Inspira has a specific like paper that pretty much you have to just go through and check off the marks just from an Inspira perspective.
You don't want to goof on, right?
Yeah.
I mean, very.
It's a very long check. So I tried to find it.
It should be.
Every
right?
hospital has it.
Yeah.
Like,
Yeah.
I mean, but you don't want to be doing
it's
it.
like
without
take
that
it,
piece
bring
of
it
paper,
out,
too.
look at it.
I should have probably brought it here before trying to talk about brain death during the lecture.
No,
But I couldn't find it. I didn't know where it was.
Well, it's going to be a policy stat, but every house has their policy, and really, I mean, because there's so many criteria that need to be fulfilled as they should be. Just print it out wherever you're working. Make sure you fulfill all the criteria before you start testing.
Yeah, Uday, you're gonna have to repeat first year because of this.
Sounds good. And then on that policy, do you need 2 physicians to be doing it with you? Or is it just?
Should be 2 exams.
It's 2 exams and 2 separate physicians.
Okay. Cool. And then finally, the last part is obviously like organ donation. This is, I think that what I've generally seen is that something that we're not going to really be taking lead on. We'll let, like Gift of Life take lead on this. And then, but I think it is important that during the entire part where you're preparing the patient for organ donation is that you're continuing to resuscitate the patient as appropriate, because you want to ensure, stability, that you don't like compromise the organs. I've seen mixed things like, whether or not to use steroids, whether or not empiric antibiotics are indicated. I think it just varies by whatever they decide to tell you.
Here's the deal with that, right? So I think that to me, it's the ultimate kind of, there's a reason they call it Gift of Life, right? For real. But it also sort of is in many ways to many families, meaningful. And so, I think that in a lot of ways it shows compassion. And a lot of people will stay alive because of it, right? So like that's a legit ICU admission if there ever was one, right?
Yeah, absolutely.
And I think that sometimes we need to kind of coach our colleagues, down that path. It's like, well, the guy's brain dead. you're right, it's brain dead, but it's. Exactly.
Yeah, I think the biggest takeaway is like, you're not stopping your resuscitation or your medical management day. You're going to continue to be active with the patient then, but obviously working with your people that you're referring to, which is gift of life. That's all I really have. But yeah, questions? Cool, thanks guys.
Thank you.
Udi, that was awesome. Thank you so much.